Thank you very much, Jerry. And now, before opening the floor to questions, I'd like to introduce two of our research and medical experts. At the far end of the table is Dr. Lynn Beattie, who's a professor in the Division of Geriatric Medicine at UBC. And she can answer your questions regarding any research to find the causes and cure for Alzheimer's disease and related dementia, or the impact of research for both more care and more effective care. Beside her is Dr. David Gayton, who's an Alzheimer Society of B.C. board member, geriatrician, and head of the Elder Health Clinic at Peace Arch Hospital in White Rock. And he can answer any questions regarding dementia, diagnosis and treatment, and the current state of dementia care in BC. So with that, are there any questions for our panel? And I should mention that any questions, could the person responding please come up to where the mic is so it can get recorded? Do we have any questions? Yes.
Medical questions in regards to early diagnosis and what kind of therapies are available now that would encourage people to come forward who are afraid to get a diagnosis, thinking nothing could be done anyway?
Maybe you both could come up here and then it'd be easier to field any questions that are here.
Could you repeat the question?
Yeah, so a lot of people who suspect perhaps that they're developing symptoms are afraid, obviously, of diagnosis. So what could you say in regards to early diagnosis that might encourage people, to get tested, to get diagnosed? Is there real help?
I think there's a lot of reasons why you want an early diagnosis. Part of it is, you see Jim Mann, he's a very functional guy. He set his life in order. He's faced issues like driving in a rational fashion. I don't know what he's done in terms of his affairs, but he probably has them well in order. What I can offer him as a physician, perhaps is not a lot. I would certainly encourage him from the evidence that he should be treating his brain the same way as you treat your heart, i.e. you should be exercising, you should be controlling your blood pressure, probably you should not be obese, you certainly shouldn't be smoking. So there's a lot of these issues, some of which are proven, some of which are not yet, that this may slow the progress of your disease. But I think from the point of view of putting your life in order, I think it's very important. There's also, I think in the future, now that people are diagnosed early, I suspect that their approach to life and their approach to the disease as it progresses will be quite different from what was seen in the past. Lynn, do you have anything to add?
Well, I agree with you completely. I think that in addition, though, I think one of the challenges we face is can we diagnose it early enough if we had some early interventions, and we don't have those available at the present time, but perhaps they're just around the corner, and if we could get more astute at that. I also recognize that there is a huge stigma as people face having this kind of a problem. Jim has faced it square on, as we've heard, but there are many people who look at the stigma of having this problem and so on. So I think part of the intervention has to be to have a sympathetic ear when you have been diagnosed with the problem, so people can say, okay, I've talked about the diagnosis. It doesn't mean that tomorrow you're going to curl up in a ball and be in a long-term care facility. It means that there's this, this, and this to do. Some of the things that David talked about and that we heard about.
You mentioned there's not a lot you can do medically, but then we also talk about the need for research, and I think we understand that there have been big cutbacks. Can you tell us a little bit about the need for research and how big of the cutbacks have been funding?
Well, there's such a huge need for research. We don't know what causes this disorder, like Alzheimer's disease or frontotemporal dementia. There's a small group of people that have a genetic cause that we've identified for that. But even when we can understand what that is, and we can even do, in some rare cases, some pre-symptomatic testing, but we still don't have something to offer them besides the things that David has talked about. So I think this is a huge challenge. So we need to do more research to understand and bring what we understand in terms of plaque development and tangle development and bring it to the bedside. And we're hopeful that some of the kinds of things that people are looking at will bear fruit. But in the meantime, we probably have to continue to do the research so that we have effective care strategies for people who have the disease, that we direct their attention to getting affairs in order, making sure their business situation is looked after, making sure that they are exercising, looking after blood pressure and cholesterol and things that we know can be helpful. But there's still underlying all this the big need to understand what the cause of this disease is so that we can get on with the cure.
And how big, just that other question, was how big have the cuts been this year that you've had to suffer?
Well, in terms of research per se, that hasn't been as big. It's just never enough to start out with. And through the Alzheimer Society of Canada, for example, we see a real challenge of a need to have more research dollars available. At the same time, we have to research about what the best care we can help people with in the meantime, because there are a lot of issues in our province. For example, my thing is assisted living is a real problem for people with early Alzheimer's disease because they don't qualify for assisted living. And so that's an issue that has to be dealt with.
In a similar vein, I mean, this is a lot about personal responsibility and awareness and approaches, but there's also a collective responsibility and awareness as well. And one of the heartbreaks of Alzheimer's is the burden it puts on families who don't have the money or the expertise to deal with it. So what kind of wake-up call has to be given to government who control the purse strings for healthcare funding, and not just in research, but in places to live, and services that they need, and support on the ground for families? Because I would suggest if we're waiting for ordinary people to figure this out, you're just going to have a tsunami of heartbreak. So what would you say to government who control the dollars?
I think the biggest cutback we've had in British Columbia is related to community services. And I see that every day when I see people in the clinic. And probably, David, you could comment on that as well in your jurisdiction.
Go ahead, burn some bridges for you.
You know, it's always easy to say the government ought to do more. I think we have so many dollars to spend on healthcare, and if you take something, if you build something, you take it from somewhere else these days. Let's be honest. But I think that we can do things a lot smarter. I think the government has moved in a good direction in terms of the BC service framework. I think they have to dust off the second document. There's a second document which was the strategies as to how you implement the framework. And that is sitting with the government, and this government, I think, has to move on that. And I think that a lot of things that you would do would be to act smarter rather than just do more. For example, they have recognized, as Jean said, that Alzheimer's is an important chronic disease which needs management. And right now, we don't manage it very well. We need to bring the care for these people into the GP's office by building a team there. We have to be smarter in terms of helping them navigate the system. There is clear evidence that if you help these people, if you help caregivers, you can keep these patients out of long-term care institutions for a longer period. I think if I'm somebody with Alzheimer's disease, I don't particularly want to be in an expensive nursing home. I want to be home with my family. And I think there's strategies which we can be making available now that will achieve this.
Given that BC is Canada's favorite retirement place, and the baby boomers are all getting whiter, and given the scope of the problem in front of us, how prepared are we to deliver on-the-ground help to ordinary people? And I'm talking about government not being smarter, but having ready to deal with the scope of the issue.
Well, I think some partnerships are really in order here in order to deal with that. And Jean mentioned in her talk some of the initiatives that have been undertaken in British Columbia. And for example, one of the programs that was looked at that was evaluated in Victoria is called the First Link program. And the Alzheimer Society of British Columbia has got that going, which is a place where people can go to get information at the early stages of the disease. So what needs to happen in addition to that is it can't be just in Victoria, and yes, there are a lot of people in Victoria that are retired, but that needs to be more universal. So that, and now we have some information from that study that was done that this is effective. And so we must implement things that we know work farther into the province. And so there are initiatives like that that we could get going with.
What kind of grade would you give the BC government?
Well, just like Obama, B+.
Just to maybe clarify something, the Alzheimer Society of B.C. receives almost no direct government funding. We mainly get our revenues from donations. We are struggling to keep up with the disease. What the concern, of course, is that the disease is growing, and if we're going to continue to help people or expand services, that's going to cost some more money. So we spent a lot of time with the government and outlining the issues. They have come back in the last couple of years with a more coordinated effort to see where we stand and what needs to be done. And they're examining that. Now, we know they've got money problems just like the rest of us, and we'll see where we go, but it's undeniable that there's going to be a greater cost, and if we're going to reduce that cost and help people, getting in early on a coordinated strategy will save everyone money, including the government, and it will benefit all the people that are impacted by this. So that's the strategy today.
How does BC compare to other jurisdictions, and is there a kind of a paragon of some kind of, I don't know, vanguard jurisdiction that's taking kind of optimal care of people with dementia?
Well, I think across the country we have evidence of pockets of helpful things that we can all learn about. I know of some in Nova Scotia, I know of some initiatives in Ontario, in Alberta, etc. But the comprehensive vision of being able to do something about this is really not present, and that's the advantage of the Rising Tide document. It demonstrates some differences from province to province.
Well, what I was thinking about was maybe, such a cliche, but I was thinking of Scandinavia, continental Europe. I mean, what are those countries doing for their rising tide problem as well?
It's really those
There-
line recommendations in the report.
Yeah, go ahead.
I think you would find in many of the northern European countries a more comprehensive approach to care of the elderly, which is something I think that in Canada we lag behind. We haven't grasped the importance that it's old people who are using our health dollars. So that, I run up what I think is a very good program in White Rock, which is a dementia pathway. I would like to retire, and I'm not retiring because there's nobody to replace me. So I think there needs to be a greater emphasis on how we deal with the elderly population, and I think we can do it much better than we're doing it. And I think that if you do that, then you will, by definition, care for the demented patients much more effectively and efficiently, and it'll allow me to retire.
I know BC is doing their research with the $5 million grant from the government. Federally, they're doing research. I wonder, are they overlapping each other? Are they collaborating? Is there a way they come together with their research and make decisions on that level?
Well, I think there's a lot of integration, and for example, the Alzheimer Society of Canada has a research department to which each of the provinces make contributions in terms of developing research projects across the country. There's also collaboration with the CIHR, the Canadian Institutes of Health Research, and we have looked at that. The Alzheimer Society of Canada seems to support people in the early stages of the research careers, and then we know that a significant percent of people that are supported by the Alzheimer Society of Canada go on and get CIHR grants. The initiative, we like to be opportunists as well, and the initiatives that Jean talked about the $1 million that was available through the Alzheimer Society of B.C. is complementary to a lot of those other kinds of things going on, and it gave an opportunity for people in the various health authorities in British Columbia to work on some projects. And I've been accused of being involved at too many levels because I kind of know what's going on. At the same time, it brings an opportunity to share the kinds of experiences, and by the way, did you know that so-and-so had done that, and so on. The other thing about any kind of project, we've been stressing that there be a good evaluation component to see if this good idea really works. And unfortunately, some of our really good ideas don't really work, but other good ideas do. And we have to be really cognizant about making sure that we put our best ideas that are most effective forward. And I agree about David's dementia program at Peace Arch Hospital. It's fabulous. And people just really have a great advantage that participate in that kind of a program for their whole dementia journey.
Yes.
Morning. I'm a volunteer with the Alzheimer Society. I facilitate a caregiver support group in West End, facilitating and, you know, I'm hearing a lot this morning about government collaboration. One of the things that I hear a lot from the caregivers in our support group is how difficult it was at the beginning to get a diagnosis for their loved ones. And I'm wondering if our GPs are connected enough with the Alzheimer Society, connected enough with dementia and Alzheimer's, and able to give caregivers the help that they need at the very grassroots basic level. In other words, are we seeing improvement in diagnosis techniques?
Yes.
I would have said the same thing.
These things take a while. As a GP, you have, I mean, I'm horrified at the thought of being a GP because you have to deal with a whole realm of things. As a specialist, it's a much easier life. And what I find is that working in a community for 12 years now and diagnosing dementia along with the GPs now are very good at it. And so that the people with obvious diagnoses of dementia are getting that diagnosis these days. What the GPs are now questioning is very early diagnosis. So I don't see anybody with obvious disease now up front. I see people where the question is this just normal memory problems with aging? Is this early dementia? What's the diagnosis? So the sophistication has gone up enormously. And I think that happens when you have some specialists in a community who are dealing with the problem. The problem is there's not that many specialists. Of course, Lynn works with the dementia program at UBC, and that's a superb place for diagnosis, but there's not that many places in BC where you can go to get that diagnosis. One of the things I think this First Link program that has been studied in this grant from the government is encouraging GPs and the families to get in touch with the Alzheimer Society, the First Link, so that very early on you make that connection, and then you have you have the Alzheimer Society and its programs, which are basically the backbone of our educational programs for caregivers and patients. So that link now, if we can go forward with that, I think that's a great opportunity for people to learn more about the disease.
I would just like to add that in British Columbia, it took us 10 years to have available for people that didn't pay for it directly the medications for Alzheimer's disease that are currently available. And they aren't miracle drugs, but they are really helpful for a number of people. In order to have some coverage for these medications, part of the development of that was to have an education program really aimed at primary care docs and other docs that would be seeing people with dementia. And those education programs were rolled out from 2000, well, probably into 2008 and so on. And I think it's really making a difference because I'm seeing a different quality of information in the kinds of referrals that I'm getting. Many of them are much harder now because it's very unusual to see somebody with Alzheimer's disease that say in the mild to moderate stages, because we're seeing the other complex ones because those other ones are being diagnosed by the family docs. And our whole Canadian system is to really encourage and enable primary care docs to be able to make a diagnosis of relatively straightforward, I can use that word, Alzheimer's disease.
How does age and onset break down? Because we know Jim is early onset, right? So that's sort of the exception rule, right? How does it break down the age?
Go ahead.
Oh, just one of the stats that came out recently was that about 10% of Alzheimer's patients are below the age of 65. So it's startling because I don't think anybody thought it was that high. And the percentage that are women are 72%?
Yeah, something like that.
I've seen two numbers, but somewhere around there.
Do we have any idea why we're seeing the manifestation of this disease at earlier ages? Is there any possible explanation?
Well, I'm interested because last evening I stopped in a care facility and I saw a 58-year-old man who had the disease, and unfortunately he has lost his language and major ability to communicate. And I guess I'm seeing more and more people that are younger, but that may be the bias of the referral to my clinic as well. We do have a population of some people who have genetic early Alzheimer's disease. That's probably less than 10% of this early onset group. But that is one population that we have started to identify.
Just an addendum to that. Remember, it is a disease of old age, so that if you look at the Canadian study on health and aging, what it saw was that at age 65, perhaps 1% or 2% of the population has a diagnosis of dementia. When you get to the age of 85 or 90, it may be as high as 30%. So there is quite a difference. It is a disease of aging still.
But you probably have to have different levels and kinds of interventions for if you have a person presenting at age 80 versus a person presenting such as Jim did. And so you have to look at the whole spectrum, even though we know that age is the biggest risk factor. But we also need to keep in mind that not every old person gets demented. And to attribute some cognitive changes always to Alzheimer's disease is not a good thing either, because there are things that we need to look at. For example, they may be taking too many of the wrong drugs or something like that. So we can't just write it off that because the person's old that they have a dementia. They may have other things that are causing their cognitive impairment.
Okay, well, I want to thank everyone for coming out here. I guess our messages are there's absolutely a problem. It's certainly growing, but with proper foundation and plans, we can limit the impact on society, both in terms of human and capital costs. So thanks again for coming. There is hope out there, and let's all address the issue. Thank you.